Greetings. I thank the organizing committee for inviting me to deliver a talk on managing chronic pain. It has been rightly said that time is a great healer, but we do it best. And I bring with greetings from PGIMS Rohatak, Haryana, where I am currently working. And this is our OPD complex. And this is our pain management center, which we call it as Dard Nivaran Kendra at PGIMS Rohatak. It's a huge complex. And I'm happy to share with you that we have got a very heavy OPD, just like any other medicine, gynae or surgery OPD. And we see around 150 to 175 patients per OPD and around 30 to 40 blocks in the pain OT in the pain management center. And another OT is in different blocks, where we give fluoroscope guided blocks, around 20 to 25 per OT. And there is a dedicated day for USG guided blocks. These are some of the pictures of our pain OT of the pain management center, 6-bedded pain recovery room, and a big waiting area for patients to be comfortable. Well, I shall be focusing today on chronic pain management vis-a-vis anesthesiology postgraduate perspectives. So what should anesthesia postgraduate resident learn during its residency about chronic pain management as per the revised NMC curriculum, and how to build up a career in chronic pain management. After decades, IASP has revised its definition of pain on 16 July 2020 as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And there are 6 different notes to it, which all our anesthesia residents should learn by heart. So in the competency-based PG training program for MD anesthesiology, it was released in September 2019, and it clearly states that MD anesthesiology postgraduate must possess and demonstrate abilities to manage chronic pain and practice different modalities of chronic pain management, including pharmacotherapy, opioid and non-opioid analgesia, intervention blocks, neuroablations, physical therapy, and cognitive behavior therapy. The resident must demonstrate the ability to assess the patients with chronic pain, including thorough history taking, good physical examination, which is a foundation for any chronic pain management, and interpretation of investigations, especially the CT and MRI scans, including X-rays also. They should be able to demonstrate difference between acute and chronic pain management and classify the pain into acute and chronic pain into nociceptive pain, neuropathic pain, or a mixed pattern of pain, and also cancer pain. So this is the structure of ISP classification of chronic pain, where we talk of chronic primary pain and chronic secondary pain. And these all should be well read and well understood by all the postgraduates. We should tell them about the knowledge of pain pathways in detail, including the different theories of chronic pain, including gait control theory, intensity theory, specificity theory, and so on and so forth. As per the NMC curriculum, in the first year, there should be introduction to acute and chronic pain and pain management. In second year, there should be focus on care of terminally ill and hospice management. And in third year, the focus should be on chronic pain therapy, therapeutic nerve blocks, and conventional and alternate modes of management. During the 6 to 24 months of the residency, they should be posted exclusively in pain clinic for 1 month. So it's a multimodal approach of pain management, which comprises of pharmacotherapy, interventions, psychological support, exercises, and complementary and alternative medicine. So this is a multimodal approach to the chronic pain management. Our residents should possess knowledge and principles of management of nociceptive pain, which includes myofascial pain, lower back pain, intractable angina, burns, chronic pancreatitis, and peripheral vascular disease. I shall give you a glimpse of all the patient scenarios which we daily see in pain clinics, so as to orient yourself what type of patients, what knowledge you should have, and what patients will come to you in pain clinics. Myofascial pain syndrome is very common thing where the trigger point is the pain generator, and pressure on the myofascial trigger point patient recognizes as some or part of its pain. And trigger point injections are the mainstay of this particular disease. And you give trigger point injections with the finer needle of 25 gauge and do it in a fan-shaped manner. You go directly perpendicular, then go laterally and medially. Local anesthetic rinsed with small amount of corticosteroids, and they can be in neck, paraspinal muscles, upper back, and lumbar region. Similar scenario, but totally different, is fibromyalgia, which is characterized by widespread pain in muscles, ligament, bursa, tendons, and multiple tender points for more than 3 months with no specific cause of pain. And these are the tender points, which are absolutely different from trigger points of myofascial pain syndromes. These tender points are located in deep soft tissues, joint capsules, and periosteum, and they are the characteristics of fibromyalgia. This is an old diagram of fibromyalgia tender points. And fibromyalgia is associated with poor sleep, headache, IBS, and typically the symptoms wax and wane. There are good days, there are bad days, good weeks, good months, bad months. And treatment is comprises of anti-epileptic drugs like gabapentin and pregabalin, tricyclic antidepressants, amitriptyline and duloxetine, NSAIDs, and tramadol. And most importantly, patient self-management. In our pain clinic, we have got a fibromyalgia group room where patients of fibromyalgia come together on a particular day, discuss how they are managing pain. Moving to back pain. In India, it is very important to have history and clinical examination. MRI proven, because caries spine is not uncommon in India. Initial treatment is conservative therapy of analgesics, neuromodulators, muscle relaxants, physiotherapy, and precautions. And the neuromodulators usually are gabapentin and pregabalin combined with nortriptyline. But if these are not sufficient, we go for interventions. And as per NMC curriculum, our residents should practice epidural injections at all levels. They should also have knowledge of fluoroscope and USG anatomical imaging. So selective nerve root blocks, they are the mainstay of any patients with the radicular component of pain. Like this is the right side L4 pain. So you can very well establish that you're attacking the right side L4 nerve, and there is anterior epidural spread. So selective nerve root blocks, they are done under fluoroscopic guidance. You need to have a fluoroscope in the OT. And the other route is caudal epidural, which is good for, this is the epidural space, and you're putting needle under the guidance, and you can spread. And there's typical Christmas tree appearance of a caudal epidural steroid injection. These are good for bilateral L5S1. This can be done under USG guidance also, where you can see initially you can put a transfer probe and see sacral cornu, which is an inverse reverse U appearance, and then sacrococcygea ligament, sacral hiatus. Then you turn it in the different direction and see that your needle is inside the epidural space, and then put a color pattern and you see a mosaic when you're injecting the drug. That approach for epidural injections is a midline interlaminar, which can be done in lateral position, sitting position, or prone position, and you confirm it under fluoroscopic guidance. And nowadays we have started doing parasagittal epidural injections also. We go into the far lateral and suppose the pain is there in the right side L3, L4, L5. So instead of going for 3 nerve root blocks, you do a parasagittal epidural injection. If pain is there in the cervical component, then we go for a cervical epidural. You can go for a single shot cervical, or you can put a catheter also for a difficult patient, where you can leave the catheter in situ, go for non-particulate steroids, and usually we go for saline and inject either as a single shot or for 3 days consecutively. If patient has undergone surgery and still patient comes with post-back surgery syndrome, you have to go for epidural additional assays with either REX catheter or PVC catheter. And normal saline and 700 days are added. So this is a patient who has undergone surgery and dye is coming up to here, but the pain is coming from this source. So we have to do epidural additional assays and ensure that the drug goes up. So you do epidural additional assays and achieve the drug spread up to the affected compartment. Moving from herniated disc to the facet joint, which is primarily a syndrome which is diagnosed on the basis of clinical examination, pain on extension and lateral rotation. And usually we go for either intra-articular facet joint block or medial branch block, usually at 2 levels, one above and one at the affected levels. And we can go for a diagnostic block and then subsequently go for a radiofrequency denervation. So this is pictures of the intra-articular facet joint injections. And you can go for a medial branch block. Initially, you can go for a diagnostic one, and then subsequently you go for a radiofrequency ablation of the medial branch. Moving further down to the hip joint, we all know that THR is a definitive procedure, but some patients are not affording, not willing, and they have taken all conservative treatment. And to improve their quality of life, we go for intra-articular injection of hip joint, either with corticosteroids or PRP, under fluoroscopic guidance, anterior approach, and you typically see this halo sign or a necklace sign. And so just like female's necklace, anterior part is visible, and you know that the drug is spread all around the capsule. Moving further down, coccyx pain occurs, coccygodynia, when there is a fall in washroom on stairs. 80 to 85% are managed conservatively with analgesic and anti-inflammatories and ring applications. Those who do not well, we go for ganglia and power block, either under fluoroscopic guidance, prone position, and there are different approaches. You can go for intercoccygeal between the first and the second coccyx, or you can go for the sacrococcygeal between the sacrum and the first coccygeal bone. So this is reverse comma shape appearance, and then you free the whole spread of the dye accordingly. And these are pictures. We can go for a neurotic block. Usually patients who are having orthopedics patients, young patients, history of fall, we go for plan with local anesthetic and corticosteroids. But patients with C rectum and C perineum, we go for neurotic block with 6% phenol, around 4 to 6 ml. And you can also go for a radiofrequency ablation of the G impar, and it's also quite successful. The buttocks, the pain can come from piriformis syndrome, and you inject 1 centimeter below and 1 centimeter lateral to the lower end of the SI joint. It's a typical diagnosis, and you have to be very, very sure where your needle is going based on clinical examination, history, and then you do a fluoroscope guided injection. These are pictures of piriformis syndrome, and then patients can have pain in SI joint, and he can present as SI joint arthralgia, either because of osteoarthritis. You have to rule out caries also. At times there can be neoplastic infiltration also. Once conservative interventions fail, you go for SI joint injection, either under fluoroscopic guidance. You can introduce at the lower 1/3 of the SI joint and see a typical good spread all over the joint, as you see in these pictures. Or you can go with USG guided injections also. So this is the PSIS, and this is the sacrum, and then you go under fluoroscopic guidance. Moving further down to knee joint and osteoarthritis. It's a very, very common, we see in our families, in our parents, with our old teachers. They also come with this particular problem. Initial treatment is conservative, and we definitely go for X-ray knee, weight-bearing view, and do the grading of the osteoarthritis. Always ensure that the blood sugar is under control. Usually patients have exhausted the pharmacotherapy, and for improving the quality of life, some patients are not willing for TKR or want to wait for TKR. You can go for either the most common, which we are doing right now nowadays, is intra-articular injections of platelet-rich plasma into the knee joint and under fluoroscopic guidance. And you see that there's a whole spread into all 3 compartments. Sometimes we do also intra-articular injection of local anesthetic and corticosteroids, but we now commonly do it under fluoroscopic guidance, because with such bulky knees, we don't know whether the drug is going into the compartments of knee or not. So we do a fluoroscope guided intra-articular injections, and we ensure that the drug is reaching in all the 3 compartments. Even patients who come post TKR and still have pain, either because of bursitis or residual pain, we have to go for intra-articular injections under fluoroscopic guidance. At times we do it under USG guidance also. It can be done if fluoroscope is not available. You see for the femur, patella, and the Hoffman pad. And if the third drug which is used in addition to PRP, local anesthetic, and combination of corticosteroid is high molecular weight supplementation, viscosupplementation, the hyaluronic acid, either Synvisc or Hal1, which is available, whichever is available, and do it under fluoroscope guidance. Other modality of management of knee pain is genicular nerve block. 3 nerve blocks are given at the inferior medial. superior medial, and superior lateral. You can do it under fluoroscopic guidance also, or you can do it under USG guidance also. So 3 blocks are given, and you can do it with local anesthetic and corticosteroids, and subsequently you can do a RF ablation of genicular nerve blocks. These are the pictures of RF genicular nerve blocks ablation. We have done post TKR RF of genicular nerve block also, and patients were having residual pain, and 30 to 40% pain relief was achieved with genicular nerve block in post TKR patients. So radiofrequency ablation, so far we have discussed as applications in facet joints, and we will be discussing that useful in stellate ganglion, lumbar sympathectomy, trigeminal neuralgia, genicular nerve block we have discussed, and superior epigastric plexus block. Moving down to the further down feet, plantar fasciitis is a common thing seen in young females, calcaneum spur, and you can do it under anatomical landmarks guided or under fluoroscope guided, either with local anesthetic and corticosteroids or with PRP. Shoulder pain can come from joints, muscle groups, and bursa, and we have to always ensure that if there is associated sympathetic syndromes, rule out shoulder hand syndrome, always ensure that your endocrine profile is normal or under control. And patients usually have treatment with NSAIDs, physical therapy. Our role comes with either PRP injection of the shoulder joint or intra-articular injection of local anesthetic and corticosteroid or the shoulder joint. The next modality is suprascapular nerve blocks. You can do it under anatomical landmarks guided in the OPD as a daycare procedure, or you can do it under USG guidance where you are very sure that you are going, the supraspinatus muscle and transfer scapular ligament into the suprascapular notch and putting the drug there. So far we have discussed about disc, facet joint, coccyx, SI joint, piriformis, hip joint, knee, feet, and shoulder. Now coming to the face, patients from dental OPD also comes for TM joint, and TM joint pain can come from muscles or the joint or both. And TM joint injections can be done under daycare procedure. You inject between mandibular condyle and glenoid fossa of zygoma. Around 2 ml of solutions, 1 to 2 blocks at an interval of 2 weeks is usually 70% pain relief is achieved. Moving from nociceptive to neuropathic pain syndromes, our residents must know the principles of management of neuropathic pain, the trigeminal neuralgia, post-herpetic neuralgia, complex regional pain syndromes, and phantom limb pain. So treatment initially is anticonvulsants combining of carbamazepine, gabapentin, and pregabalin, combined with antidepressants, amitriptyline, duloxetine, and topical agents like capsaicin, opioid and non-opioid analgesics, and sympathetic blocks. So trigeminal neuralgia is a painful disorder, sudden, sharp, lancinatic pain in one or more divisions of the trigeminal nerve, usually unilateral, and patients can have pain while having shaving, washing, air blow, eating, drinking, and talking, and there can be associated features of depression. MRI has to be done to rule out any tumor, vascular malformations, multiple sclerosis, or vascular compression of the trigeminal nerve. So initially, first line of treatment is medical carbamazepine or carbamazepine, and second line treatment is gabapentin, pregabalin, lamotrigine, or baclofen. And if nothing is responded, we go for blocks. So the blocks of supraorbital and supraorbital nerve are done in a single sitting. You can do it under anatomical landmark guided or fluoroscope guided also. Patient may have associated post-herpetic neuralgia also leading on to pain in the supraorbital and supratrochlear division, or you can go for, if pain is there in infra-orbital division, go for infra-orbital nerve block. And if pain is there in the mental, you can go for a mental nerve block. At times, there will be pain in the whole of the mandibular and maxillary division. So you go for a diagnostic blocks of either the mandibular or maxillary or both of them. And once pain relief is achieved, you go for a radiofrequency lesioning of maxillary and mandibular nerve. So you can do a conventional radiofrequency lesioning of maxillary or mandibular nerve done under fluoroscopic guidance, or you can do a pulsed lesioning also. And at times we combine both conventional as well as pulsed. Some role have been done, studied on role of Botox in trigeminal neuralgia, but not much encouraging results have been achieved. If pain is restricted only to the inferior alveolar division, then you can go for inferior alveolar nerve block. From trigeminal neuralgia, moving to the post-herpetic neuralgia, pain may be there at conventional sites or unconventional sites. The conventional sites are this thoracic dermatomes, and initially patients usually go for early cyclovir, pregabalin, amitriptyline, tramadol, and if nothing is working, you go for nuchal nerve blocks, thoracic epidural, intercostal blocks, and deep infiltration of lesions. So whatever the patient feels like, if unconventional site, you can go for deep infiltration of lesions. Otherwise, you can put a epidural catheter, or you can put a intercostal nerve blocks. Lots of patients come with scar neuralgia, usually after laparotomy or after laparoscopic surgery, if especially the port has been made near to the costal margin. And if they are not responding to the conventional treatment, you have to go for the deep infiltration of scar without disrupting it. From trigeminal neuralgia to post-herpetic neuralgia, moving on to complex regional pain syndromes. Patients come with brachial plexus injury and post-trauma also, and there is dystrophy of the skin, color changes, nail changes, temperature changes. These particular patients who had brachial plexus injury and nothing was responding, so you go for a radiofrequency ablation of the brachial plexus. And yes, 40 to 50% pain relief is achieved after 2 to 3 sessions. Patient may be having trauma also, some plates and screws will be there, and but you can easily negotiate the needle towards the brachial plexus. And these are the patients of post-traumatic, post-fracture. You can see the skin changes, nail changes. Typically, patient may have burning sensations and allodynia. So you can see the skin and dystrophic changes of complex regional pain syndromes. Patients come with phantom pain also, and they come with stump pain also. So for stump pain, you can go for local injections, and for phantom pain, the treatment involves drugs, gabapentin or pregabalin, physiotherapy, psychological therapy, and occupational therapy. And if nothing is working, you go for fluoroscope guided or USG guided stellate ganglion block, and at the level of C6 H6 tubercle over the longest climb muscle, and see the good spread of the dye. So these are the pictures of stellate ganglion block. And for the lower limb, you go for the lumbar sympathetic block, initially a diagnostic block, followed by a radiofrequency ablation. These are the pictures of RF of lumbar sympathetic block. Patient of CRPS of lower limb. We are attached with the big orthopedic hospital also, and lots of patients with spastic do come. And our role is to go for obturator nerve block, initially diagnostic and then neurolytic. We do it under USG guidance and peripheral nerve stimulator guidance to release the spasticity. First a diagnostic block and then a neurolytic block with either 50% alcohol or 6% phenol. And then occupational therapy or the physiotherapist takes over. Our institute is attached with a good regional cancer center, also big one. So we are managing cancer pain also, and our residents must know practices and principles of management of cancer pain, including the WHO ladder and the revised WHO ladder, where you can go from 1 to 4, depending upon the pain score. If pain score is 10, go for interventional block and high dose of opioids. If pain relief is less, you can come down to ladder 3 also. So we have to see individual patients and ensure that if patient is able to take the medications by orally, it's fine. But if they're not able to take orally, you have to give patches, and buprenorphine patches 5, 10, 20 milligrams is available, which has to be changed every 1 week. And fentanyl patch of 25 and 15 are available, which has to change every 3 days. And interventions are commonly done for a malignancy of CA pancreas, CA gallbladder, CA liver, CA stomach, bilateral celiac plexus block, under prone position, under fluoroscopic guidance is the commonest procedure. You can do it under USG guidance also, anterior approach, but we commonly do under fluoroscopic guidance. Initially a diagnostic block with 1% alcohol, and then subsequently in the same sitting followed by 5 ml of 50% alcohol. An intraoperative celiac plexus block is also done in patients with unresectable CA pancreas. Patients with vertebral mets and radicular component of pain, we do epidural analgesia and put an epidural catheter there. For the patients with CA breast, some optimistic results have been achieved from suprascapular nerve block with patients who have get pain in the affected upper limb. 30 to 40% pain relief is achieved by giving repeated injections at weekly intervals. Patients with CA tonsil, CA head and neck, glossopharyngeal neuralgia is there, and we go for glossopharyngeal nerve blocks, intraoral approach is not possible, so we go for extraoral approach. But at times, extraoral approach is also not possible because of the mets or the swelling. So we go for the extra-mandibular approach. And our residents must also know about something about the advanced modalities like dorsal column stimulation and deep brain stimulation. So spinal cord stimulator there should be some brief about spinal cord stimulators and about the intrathecal drug delivery systems. Residents should also be talked about management of pain in special subset of patients like elderly, children, disabled, intellectually handicapped, and those unable to communicate. And the association of pain in elderly, especially the age-related physiological changes, the importance of coexisting diseases, and patients may have drug dependency also. And something we should teach them about basic principles of palliative care also. And with this COVID pandemic ensuring, we should ensure that there is no disruption of pain services across the country. And at the same time, we take care of our healthcare workers also, the doctors who are sitting in the pain clinics, they don't get infected. And there is some role of telemedicine also. This is an article in IJA about telemedicine for chronic pain management. I'm one of the authors. And I conclude that, yes, definitely when we come to redesign healthcare services in the pandemic, maybe telemedicine will be another model of care with patients with chronic pain. And do procedures according to the recommendations of Indian Society for Study of Pain Position Statement. And we should also ensure that once our residents are taught about these other implications, how they can build up a career in pain medicine, we should teach them that these are the all possible modalities where you can have an exclusive career in pain management, because we are well versed with the art and science of treating pain, and our role as a pain physician is a natural extension of the professional work. The curriculum has been designed by NMC. Onus is now on HODs of anesthesia and HODs of pain clinics and pain management centers that the postgraduates are imparted proper teaching and training in chronic pain management. There are different programs available, 1-year fellowships, PDTCs, and postdoctoral fellowships at BHU, SGPGI, and at some places GM in pain medicine has also been started, and some fellowships of WSA, IASP, ISSP, FIPP are available, and they are being conducted in different centers across the country. You can go to the net and search for them. And very happily, I will share with you that FNB in pain medicine has been started, and I, along with my whole team, as I was the convener of Specialist Board of Anesthesiologists, and we were able to pursue that to start this FNB in pain medicine. So it has been notified, an exam will be held this November, and it is a very important and long sort of dream. And due to the persistent efforts of the ISA National Secretariats, along with the dedicated team of pain physicians and senior anesthesiologists, this pain fellowship has been started, FNB in pain medicine. It is a dedicated 2 years program, and for all DA, MD, and DNB anesthesiology residents. The next aim is to start DM pain medicine in all institutes, and we are working towards it. So to summarize, chronic pain management comes with challenges. You have to treat with all strata of patients, rural to ministers, poor to rich. You have to perform from basic to advanced interventions, immediate to delayed interventions. You have to treat the patient individually. Aim is to improve his quality of life and make him pain-free. There are avenues also for clinical exposure, training and teaching, research, and establishing pain medicine as a super specialty of anesthesia. And most importantly, we get blessings of patients, which are very, very helpful in our life. So chronic pain relies on a solid foundation of history, examination, relevant investigations, and appropriate interventions. Then only, this is the Dahi Handi festival of Mumbai, then only this matki of pain will be broken. So it's a holistic approach. These pictures are not of my own. I work with my pain team, and there are boys and girls, and we work late hours in the institute, and the credit goes to the whole team. These are the pictures before the COVID with no mask. Now the things are different. We do conduct live workshops on interventional pain management also. So finally, to my dear postgraduates who wish to start career in pain medicine, one day or day one, you have to decide. Don't wait for one day. Today is the day one, and think, dream, and start your passion for building a career in pain medicine. Because magic is believing in yourself. If you can make that happen, you can make anything happen. So believe in yourself and start your passion for building a good career in chronic pain and relieving the humanity of chronic pain. I am thankful to all my teachers and parents whose teachings and blessings I am sitting here and discussing about chronic pain management. Thank you very much.